Okay, tell me what you see.
That looks great.
Oh, good. Hallelujah. Well, thanks for having me. The way this looks on my screen, I can't actually see any of you. So if anyone's like raising their hand or wants to chime in, I won't see you. So you'll have to just kind of jump in, I guess, if there's something pressing. So, and you see something that just says functional neurological disorders on the home, like main page.
Yes.
Awesome. Great. I have no disclosures. Oh, and because there's not a case from the crowd today, I have put in a case of my own embedded throughout this talk. So Kurt LaFrance is a psychiatrist who he's actually a neuropsychiatrist who is very well known around the world. Is one of the world experts in functional disorders and also known as conversion disorders. And so here's what he has to say. Conversion disorders are disorders of communication and language, not necessarily aphasias, but disorders of expression, in some ways, a cognitive dyspraxia of self. The cure comes in knowing oneself. He's actually a regular speaker at the band conference. If any of you have come to that in Sun Valley, we do that every other year. So today we are going to become familiar with a variety of names that are used to describe functional neurological symptom disorders. We're going to recognize the signs and symptoms of these conditions, and we're going to come away learning how to differentiate between an epileptic seizure and a non-epileptic seizure. Particularly important if it happens in your office in front of you, you don't have access to an EEG. So there are some telltale signs that you can look for. So today we're going to talk about the happiest kid. And so my practice is nearly exclusively in the hospital, although I am in an ambulatory clinic today working. But typically I see consults in the hospital and I get a call. And here's how it goes. Hey, we have an 18-year-old female with left-sided blindness, left-sided weakness, and a facial droop. Oh, and stuttering, who came in for a stroke. Neurology thinks this is conversion disorder. So I say, okay, well, what else do we know about her? And the person calling me says, well, it sounds like she had an eye exam consistent with blindness. But when we followed up on with MRI, it was normal. And so I ask, are there any notable labs or medications? And the answer is no, there really aren't. And this is what the family had to say about the patient. Tasha has always been the happiest kid. Nothing ever gets to her. So when that doctor told us there was nothing wrong with her, we knew that couldn't be right. I mean, how in the world could someone just make this happen? And so I asked, well, what have you observed? And they said, well, she's so weak on the left side that she can't walk. She's been blind in her left eye since about 4 months ago. We went to the eye doctor and they hold up a visual field test result. She is completely blind on the left side of that left eye. That is proof. And the poor girl can't manage to get a word out. I don't know why they keep talking to us about stress. She is not stressed out. Oh, and by the way, we also have a picture of her when she had that stroke. And so then they pull up on the phone a picture of her left-sided droop with intact nasolabial folds. And those are these little folds you have right here on the outside of your nose. So as far as past psychiatric history goes, because of course we're always going to want a really, really thorough history, she has no past psychiatric history. She has no past family psychiatric history, no significant medical history at all. She has had an appendectomy and a cholecystectomy. And remember, this is a teenager. So that's a lot of surgery for a teen. As far as labs go, we have had a CBC. a Chem 10, a urinary toxicology. Those are all within normal limits. She has had an MRI brain without contrast 3 times, normal. She had an MRI brain orbits with and without, sorry, the MRI brain without, and the MRI brain orbits with and without, normal. She had a CT angiogram, head and neck, normal. She had a TTE, so it's an echocardiogram, normal, with bubble, normal. And her CSF was normal, so her spinal tap was normal, lumbar puncture. So I evaluate the patient, and I've underlined what is unusual or really stands out in her evaluation. And so, she's a normal looking young woman. She's groomed normally. She's at that time doesn't have any noticeable facial droop. The facial droop in the picture I should demonstrate for you. The picture, it was like this. I don't know if you can see that left-sided droop there, but not now. That's resolved. She looks like she's got normal muscle tone. I did not check her gait, meaning I did not get her up and walk her. Typically, we like to walk people, but with her weakness, we did not do a walking evaluation. She did have some facial twitching, kind of when we spoke. She kind of had a little bit of a twitch here and there, some grimacing, a little bit of tongue thrust, which is just like and with the grimacing, and then kind of a twisting when she would speak that would also come with a shoulder twitch. So kind of like very upsetting to the family. And she had this severe stutter, which is not the type of stutter we hear with a developmental stutter in a child. This is as if she were trying to spit out words, and it was a very loud volume. She was trying to talk to me very loudly. And kind of a decreased spontaneity when I didn't ask her a question. She wouldn't, or when I asked her a question, she wasn't really elaborating. Just minimal answers to questions. She was cooperative, but not particularly engaged or curious or interested or really not seeming that concerned. Her family, on the other hand, many of whom were in the room, were very concerned on her behalf. I asked her how her mood was, and she said tired. And her affect. So mood is, we put it in quotes, it's the exact wording that patient says about themselves and how they're feeling. And then the affect is what I see. And so she was restricted, very minimal expression when speaking, aside from the tics and the movements, and limited reactivity. She was indifferent. But her thought process was logical, linear, and goal directed. She didn't seem paranoid or delusional. She wasn't perseverative. She was awake. She was alert. She was attentive. She was oriented. Her memory was intact. So I started to have thoughts in my head about what could be going on. And the family had been giving this a lot of thought. They had ideas of what was going on. And so they've done a ton of online research. And this is what they have come up with. They think, these doctors, they're missing a stroke. Maybe she has new onset Tourette syndrome. Could this be Bell's palsy, where you get a partial kind of a paralysis in the face? Worse yet, even they're thinking, could this be Huntington's disease, which is a genetic condition? Could this be multiple sclerosis? Maybe, she's a young woman. Young women may be starting to show signs of multiple sclerosis at this age. Could this be a partial paralysis situation, or is this even a heavy metal poisoning? So, what's on your differential? You can put some thoughts into the chat. And again, for some reason, the way my screen is showing up, I can't see what you're putting in there. So if anyone wants to unmute and just say what's on your differential, I would be okay with that, but certainly you don't have to. Let's see. Oh, I just can pull down the screen. But let's see, is anyone brave enough to say what they think is going on? I mean, we are, after all, at a functional disorders talk. That would be the safest bet.
Sorry, I kind of
Okay.
came in late, so I didn't hear everything. But
Oh, I
one,
cannot hear you very well. Can other people hear who's talking?
can you hear me very well?
That's a
Um,
little bit better.
yeah, a little quiet.
Um, I guess one thing I also think of is like a post-streptococcal, like panda
A
or
pandas or a pans? I think that's a really good thought. Yeah. Okay.
Somebody wrote migraine in the chat.
Yeah, like a complex migraine. Yeah. Any other thoughts? Okay. So what's on our differential? So primary neurological condition, right? Like complicated migraine, pandas, PANS, um, or a functional neurological disorder versus even someone might think this is some sort of malingering. So here are the arguments that it's a primary neurological condition in my mind. We have an eye exam concerning for blindness. We have symptoms that seem neurological, like the droop, the weakness, and the stuttering. And the family's denying any stress. And we don't always see stress with functional disorders, but very often there's an association. Then the argument for the functional neurological disorder, 4 negative MRIs. So if we had stroke, we would see that. If we had MS, we would see that. So those are off our differential, off the parents' differential. They had a differential of Huntington's. This is a familial disorder, and its form of inheritance is what's called penetrant, meaning that you see it in each generation. No one has had this before. Negative CSF. If this were a PANS or a PANDAS conditions or an autoimmune encephalitis picture or some sort of infection in the CSF, we would likely see abnormalities in that CSF. Her speech is atypical. This abnormality is not like what we would expect with a stuttering, a developmental stutter. Typically, people who stutter developmentally, and if there are child psychiatrists in the room, feel free to chime in, or those who work a lot with children who stutter, chime in. Typically, in stuttering children, there is a fear factor, if you will. There's an anxious component to it. It's not typically loud and booming. It's hesitant. It's halting. And then once the words come, they come. This was different than that. This was abrupt. This was loud. This was staccato. And it was distractible, meaning when I could get her to talk about something else or do a different part of an exam, the distraction led to no stutter. So there was no neurological explanation for a particular clustering of symptoms. The reason I raised the nasolabial folds in the examination portion and why that was notable to me is that in a stroke, we expect to see, if there's a droop, we expect to see a softening of that nasolabial fold where we are losing this line. And in this patient, just like and I am not saying that she was purposely doing this, don't misunderstand me, but you can cause your own droop, but you don't lose your nasolabial fold. The nasolabial fold is supported by the musculature, and in stroke, the neurons that support the musculature will fail, and we have a softening or a loss of this nasolabial fold. In a patient without stroke, but with droop, we just don't lose the fold. And so when I make my own droop, I have a fold. So this is, our physical exam is important. And this is one reason why, because we can see things that we expect to see. And if something we expect to see is absent, this is a concern for a neurological problem. Visual fields. Now, this is a really interesting thing. I bet many of you wear contact lenses or glasses, and you have gone to the eye doctor to have an evaluation. And at your eye doctor, they probably have done a visual field test. If you go to a fancy eye doctor, they have what I call the video game. I don't know, you could raise your hand if you know what I'm talking about. Like when you go to the eye doctor, you play the video game, which tests your visual fields. And so how this works is you lean your head into this machine and your forehead's pressed up against it, and one eye is covered, and you have a clicker. And every time you see a zigzag line in your peripheral vision, in your central vision, you click the button. It's a little bit anxiety provoking. Like when I take this test, I'm like, oh my gosh, am I going to be losing my peripheral vision because I don't like notice something? And so like, I think probably I overclick. So I'm like, oh, did I miss one? But every time you see the zaggy line, you click the button and it marks it in their computer. And then their computer spits out information that shows your visual fields, how wide your peripheral vision is, or how narrow it is, or where you may be losing visual fields. So I could take this visual field test and go crazy pressing that button, or I could take a visual field test and never press a button. Knowing that, what I just told you, how reliable do you think a visual field exam is in this case, where she has had negative MRIs times 4 with no concern shown? I'll say for me, I did not hold that visual field testing, or I did not find it to have the same level of merit that the family found it to have, because it is not a truly objective evaluation. So next, we're like, okay, it's looking like a functional disorder, but we don't want to jump to any conclusions. There's lots of studies out there about how biased we are, even when we think we're not. And so I really want to make this a very thorough evaluation. And so I want to know more. I want to know, like, give me more social history other than Tasha's just peachy all the time. She's non-stressed. And so here is a little more of her social history. Tasha grew up with her mother and her father and her brother. She's a senior in high school. That's a little stressful, right? She has a part-time job, and she has a child that's a year old. She has an unusual living arrangement. Hands up. Stressful or not stressful? Stressful, right? Like being in high school is stressful. Having a 1-year-old is stressful. Having a 1-year-old in high school is stressful. And what about this unusual living arrangement? What is that about? So, in this arrangement, she comes from a very religious family. And so, Tasha's mother and father are very upset that we now have a baby out of wedlock. They're very angry at the father of the baby. They will not let him come over and stay over with Tasha and the baby. But they have an arrangement with the other family that the baby will be with Tasha part time and with the father part time. So while the baby is at Tasha's house with her parents, she's with the baby, taking care of the baby, and the boyfriend is not allowed. When the baby goes to the boyfriend's house, Tasha stays there with the baby. And so this is an unusual scenario. So, and by the way, these are those scenarios where we really like, as physicians, as nurses, as any number of us who's on that care team for this patient, it can be really hard to kind of keep your mouth shut, because in some ways this ship has sailed. And it's, of course, not my place at all to say these things. I can think all my thoughts. But having a filter sometimes really is quite important, as we all know. So I maintained my filter. You'd be proud to know that I did that. I was proud of myself for it. And I just felt for Tasha and all she was experiencing. And it just felt like her family was really not able to recognize how stressful this situation was for Tasha. And to the extent that her dad said, I've been in war. I have served. I know what stress is. She has the blessed life. So imagine being told that the things on your mind, your real lived experience, were inconsequential compared to those around you. So, functional neurological disorder. I won't read this whole thing to you. This is a quote from the Functional Disorders Research Group. And basically, that top portion is saying there's a problem with the functioning of the nervous system and how the brain and body sends and receives signals rather than a structural problem. And then that bottom paragraph I will read. One way to think of FND is looking at it as a bit like a software problem on a computer. The hardware is not damaged, but there's a problem with the software. And so that computer just does not work properly. What are some other common names you've probably heard? And it can get really confusing because psychiatry has called it all sorts of things. Other disciplines call it different things. The appropriate name these days is functional neurological disorder, but you'll hear our functional neurological symptom disorder, which is what the DSM-5 adopted, but you'll hear functional movement disorder, conversion disorder, psychogenic seizures with a movement disorder. That's a subset of functional disorders. Dissociative seizures, motor disorder, non-epileptic seizures, pseudo seizures. Please don't call it that. We don't use that term anymore. FND, and psychogenic attacks. The reason we don't say pseudo seizures anymore, by the way, is it feels really judgy to patients. Patients will come away, no matter how amazing you are at building rapport with someone, they will come away and think, oh my gosh, they said it was pseudo, like I'm faking it. These people are not faking these conditions. They're actually having these symptoms. So what is the epidemiology? We really don't know the true incidence and prevalence. It's very hard to quantify. Some research indicates it's actually the second leading cause for a visit to neurology or a neurologist, second only to headache, which is wild. That's a lot of patients going to the neurologist. Who maybe otherwise might be seeing stroke patients, MS patients. It's really uncommon in children under 10, but you can see it. My very first functional disorder patient that I ever evaluated was actually at Children's Hospital in Seattle. He he was a really delightful junior high student who was very high achieving. And not only was he trying to be captain of the basketball team in his, junior high, he also was a violinist. And he was about to sit for, first chair in their orchestra in the junior high. And he woke up and his arm stopped working. Um, his parents, luckily, his mother immediately, and his parents worked at Microsoft. His mother immediately said, I think my son is really stressed, and I'm worried this could be related to that. And she was right. A very insightful family. So we get it. We get really insightful. We get really skeptical, folks, and it's good for families to be skeptical because we do not want to miss something neurological that we could, preserve brain if there's a neurological insult. So it is good that we really do a thorough evaluation here. More common in women, except after 50, then it kind of is equally men and women. Although there are some that appear more in men and older men, like a functional myoclonus or a Parkinsonism. There are a lot of co-occurring disorders. We went through those in kind of what we were talking about on our differential before. So I'll just highlight particularly anxiety and panic disorder. Anxiety, in particular, panic can and does cause many physical symptoms. And so that can start to someone's hyperventilating, having numbness and tingling. That can be mistaken for a functional disorder, but it might be a panic attack. So we have to kind of keep some of those things in mind. In Tasha, she was not panicked at all. She was indifferent. And there's a name for it that we commonly refer to in psychiatry called la belle indifférence. It's almost diagnostic. She's indifferent. She's indifferent to her condition. And when you see someone who's been blind for 4 months and yet they are indifferent to it, that is a red flag that there is potentially a functional disorder going on. We see some correlation with irritable bowel and overactive bladder in those with FND. And again, we really gotta do our best to evaluate for these conditions. So we do not know the exact pathophysiology. It's an area of interest. It's such a curiosity to understand what this kind of mind-body connection is and how, in many cases, at least in the ones that have acute stressors, we don't really know but suspect that if the body has stress that's not addressed and released in some way, whether that's through talking or therapy or even knowing the words to put on your feelings. The word is alexithymia. We'll often see functional patients who have alexithymia, meaning they are not able to name their emotions. People who don't know how to name their emotions are likely more predisposed to something like a functional disorder because the body and brain will express these things one way or another. So some predisposing factors, we might actually see this a little more often in someone who has a neurological condition. And so that can be confusing to know what you're looking at. And so you're going to kind of want to separate the past and what was present versus these newer symptoms. We see this more in folks with chronic fatigue or stress. There's a long DSM criteria. I'm not going to go through it all. You have these slides in a PDF, or you will have them if you don't have them yet. And of course, if you have I really love the DSM desk reference, the small one. If you have one of those, you can just flip to this anytime if you're suspicious that someone in front of you is having a functional disorder. Signs and symptoms, typically, they come in, I'm going to show you a couple of different ways these have been organized outside of the DSM. So you can have a functional motor dysfunction, that's a lot of function, sensory dysfunction or altered awareness. So in the functional kind of grouping, you have limb weakness or pain, tremors, spasms, jerking, walking problems, stuttering, whispering of words, slurred speech, seizure-like episodes. Or with a sensory dysfunction, and this is the one that maybe could get confused with panic or vice versa, numbness, tingling, or pain in the face or even in a body part, like the limbs, and vision loss or double vision can happen. Also, in those situations, you're going to want to screen out, like someone was mentioning, migraine or complex migraine, or an optic migraine. And then we have our altered awareness, and this we might see in someone who has a PTSD history, someone who is predisposed to disassociating, blacking out, having memory lapses. And then this is a different way of looking at it and categorizing it. This one categorizes it by poverty of movement, meaning decreased movement, excessive movement, or axial manifestations. It's 12:35. Oh, I can't see how many slides I have left. Let me see how we're doing.
You've got about 15 slides left.
Okay, yeah, so I won't go through all of these, but I think you get the point. Poverty of movement might be weakness, and I'm going to show you some things we can do to evaluate weakness, especially if one leg is weaker than the other, which is, I would say, of the weakness functional disorders I see, and I see quite a bit of functional disorder in the hospital. Actually, when I was in training, I had no idea how pervasive the functional disorders are. We saw a fair amount of them, but we see so much functional disorder in the hospitals here. So, and I'm going to show you the signs that I reference here that are the tests we're going to look at. So with a leg weakness, there's something called the Hoover sign we can look for. For arm weakness, we do something called drift. We look at a pronator drift. I'll show you that. For Parkinsonism, of course, this can be this is not true Parkinson's disorder, although people with Parkinson's who are maybe developing Parkinson's disorder are likely predisposed to Parkinsonism from medications, especially from dopamine blockade, so that it looks like they have Parkinson's. But in this sort of brand of Parkinsonism, you can tease out if it's actual Parkinson's or Parkinsonism based on some tests like a tapping test that will have slightly different results if it's Parkinson's. You can also try and distract people. Distractibility is a very helpful diagnostic tool. Excessive movement, like we talked about before, that's that kind of tremor, or the myoclonus is the jerking. Tics that aren't fully stereotyped, they might interfere with speech or voluntary actions. So tic disorders are a really different topic, and one that I'd love to talk to you about at another time. But with our tic disorders, and not everyone who has a tic disorder has Tourette's, but with a tic disorder, they're typically stereotyped. People with tic disorders tend to have the tics move. So they might have one day like a neck kind of tic. The other day they might have kind of like a eye roll, or some other kind of like a verbal tic, like a throat clearing all the time. And in a true tic disorder, there is something called it's a premonitory urge that people with tics can suppress their tics momentarily. The longer they suppress their tics, true tics, the bigger the tic is when it comes out. There is not in a functional disorder The patient is not, in addition to it not being stereotyped, they don't have that urge, that repressible urge. Yeah, and then the axial manifestation, sometimes we get like unusual walks or gaits. So someone might have an odd gait. They might swing a leg. They might have knee buckling. They might, sometimes you see kids doing funny walks and like they're dragging a foot, trying to like say that like, oh, my foot hurts, I can't go to school or something like that. But they're dragging their foot along in contact with the ground. Or they have like what I'm calling here an ice walk slowness, where they're like afraid they're going to slip on ice. And often these gait impairments are, again, distractible. If you get them talking about something, or you get them doing you come up with some kind of hand test, like you tell them that, like, okay, while you're walking, I'm checking you're walking. While you're walking, I'm going to have you tap your fingers, or, whatever you want to do. The walk will become less overtly unusual because the focus is here, even at a subconscious level. Sometimes swaying or listing to a direction. Okay, so what it is not, and this is really important, and I think we've come a really long way. People in the past maybe thought this is a bunch of fakers. And that's why patients are really sensitive to some of the terminology, and why we have to be really aware that this is not being manufactured on a conscious level by the patient. It is not a factitious disorder. They are not falsifying physical or psychological signs or symptoms or injuries. In a factitious disorder, they do. In a factitious disorder, an individual presents themselves as ill, impaired, or injured. Factitious disorder has deceptive behavior that's evident, even when we can't figure out what is the gain. This is not factitious. They are not faking it or falsifying. It's also not malingering. Can someone malinger? Absolutely. But in general, if we're looking at what we think is a functional neurological disorder, they're not doing it. They're not malingering. Malingering is that purposeful falsification, and it's motivated by extrinsic rewards of some sort. And even if that's not a reward to you, like sometimes for someone else, being in the hospital might be a reward. Getting to stay in the hospital might be a reward. These functional conditions are not malingering. So how do we do some tests? I mentioned a few things along the way that help you really differentiate what's up and what's going on. One of the really most I hate to say the word fun test, but one of the kind of more fun tests you can do is a Hoover exam. And it's checking for functional weakness. And this is a test you can only use in a patient who has one-sided leg weakness more than the other. And so I asked the patient, would it be okay? And I have a sitting version too on the next slide. So I'll say, would it be okay if I examined your legs? And they'll say, sure. So if they're lying down, we're going to do it this way. I'll say, I'm going to check your good leg first, because I want to be able to compare what's happening with your weak leg by knowing how strong your other leg is. And so I take one hand and I put it over. I don't do it quite. I'm going to show you the sitting one because I think it's a little easier to understand. So I see how they're sliding that hand. So I'm gonna just say I'm gonna slide this hand under here to kind of balance myself, and I'm gonna put my other hand on top of your good knee. Okay, I'm checking your good side. So just go ahead and lift up that good leg for me. Remember, my other hand is under the weak leg. Now, if someone truly has weakness, you will feel nothing or almost nothing pressing into the palm of your hand that's under the weak leg. Remember, the patient thinks you're checking the good leg. You're actually checking the weak leg. So hand under the leg. And if someone, you could do this yourself right now, actually slide your palms under both of your thighs and go ahead and lift up your right knee if you're able to. What do you feel in your left palm? Do it again. Pay very close attention to what you feel in your left palm. Remember, your left palm is under your left thigh. Your left thigh pushes into your left palm. So if a patient has functional weakness, you will feel their muscle of the weak leg tense and push into the palm of your hand. If they have a neurological condition, let's say you had not been able to get imaging or you're somewhere out in the field, if you feel nothing, this is very concerning for a neurological condition. If you feel nothing pressing from the weak leg into your palm, because we all have the muscle strength, even in weak people. Unless if you have a paralysis, this is not applicable, obviously, because a person with a paralysis is going to have weakness. So in a functional condition and in all of our normal states of being, our muscle will push into your palm. It's just how our muscles oppose each other. And so that is the Hoover sign. Now, when you document Hoover sign, there's a lot of confusion over like what's positive, what's not positive. And so because it can be very easily confused by a reader, when you document, I would just say Hoover evaluation is positive for muscle strength, or for you can't just say positive Hoover sign. You have to kind of be descriptive, or else no one's gonna, like, a lot of folks will be like, is this the positive or the negative sign? Spinal injuries test. This is also a test for weakness. So when someone tells us they have lower extremity weakness, what we're going to do is they're going to be in a resting position. They're going to be unable to lift their legs because they're weak, and so we're going to raise their legs for them, and we're going to hold them. And if they just hold up right like that, we have a functional concern. If they flop over, we are more concerned about something neurological, because you wouldn't be able to hold your knees up if it was neurological. This is that sign we use for the upper body weakness. So if someone's presenting to us with the upper body weakness, they're saying like, hey, I am experiencing weakness in one arm more than the other. Arms are a little more tricky than legs, at least for me. Probably not for like an orthopedic surgeon or a sports medicine doc, or a family doc. But for me, sometimes the arms can be a little more confusing because we've got we have shoulder issues that people have. We have autoimmune conditions that can cause difficulty with people raising their arms. So I personally find the arms a little more difficult. But with this particular sign, what we're going to be checking for is something called pronator drift. And so we're going to ask the patient to put their arms out. And an organic drift, meaning that there is an organic cause of the weakness, is they're going to kind of drift, and then you see in the picture how the drawing's hand is kind of turned. They're going to kind of drift. But with the functional drift, we're not gonna have that pronation, and we're just kind of gonna go in different directions. And again, a little more tricky and kind of hard to demonstrate. I wish if we were in person like the good old days, then we could have a willing participant join me up here and we could go through that. So physical signs of weakness, if someone's eyes are squinted shut, that's functional. And if you hold them up like this and they kind of like roll back, functional. This is explaining kind of that visual field defect evaluation. And then I want to talk for a minute here, and I think we're on slide 28, but we're moving right along. So we're going to wrap up in just a couple minutes here. So epileptic versus non-epileptic, psychogenic non-epileptic seizures, these are a subset of the functional disorders. And there are ways we can differentiate them even if we don't have an EEG. Okay. So we want EEG because that's a more definitive test that families and patients are more likely to believe the results of, because people like to see labs and images and tests. But physical exam is hugely important in functional evaluations, and this is one area we can really make the diagnosis. So the duration of an epileptic seizure, typically in Western status, it's going to be short, 1 to 2 minutes. Obviously, if they're in more than 5-minute seizure, that could be status if it is epileptic, very concerning, obviously. We want to get that person care immediately. Psychogenic non-epileptic seizures usually last and last and last and last and last. Eyes in epileptic events are open. Non-epileptic events, squinted shut, and you can force those eyes open, but they're squinted shut. Motor activity in epileptic seizure, especially if it's a tonic-clonic, what used to be called grand mal, you're going to get a stereotized, synchronized building and progression. You're going to get so in someone who's having a grand mal, you're going to get a tonic. I'm going to show you my arm is going to ratchet up. Tonic, 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 tight, clonic. Right? Eyes wide open, tonic, clonic. That's not what we see in a functional seizure. In a functional seizure, it's variable. There's a lot of flailing. There's a lot of movement. There's some pelvic thrusting, potentially rolling. It waxes and wanes. Not as common in epileptic events to have a lot of vocalization, especially if it's a convulsive episode. If it's a partial seizure, this is a little different. A partial seizure, especially like the auditory cortex, you may actually have someone cussing, making all sorts of vocalizations. Vocalizations in non-epileptic seizures are pretty common. Prolonged atonia, meaning like you're kind of flaccid afterward, is very rare with epilepsy, could occur in non-epileptic seizures. Incontinence, meaning we lose our urine, very common in convulsive seizures, less common in non-epileptic seizures. So, one thing that and this is, we don't have time to go into a really protracted explanation of how a generalized seizure happens, but what I will tell you is that if you're having a generalized seizure, that means, so if in order for someone to be having a seizure where both sides of the body are involved, like shaking on both sides of the body, that means it is a generalized seizure that has spread across both hemispheres of the brain. If both hemispheres of the brain are involved, then a person cannot have consciousness. They do not have consciousness. And that means they don't really hear you. They can't speak to you in a meaningful way. So if you have someone that you see in your office and they're having a flailing event, and they're talking to you and they're like, I'm having a seizure, that is a non-epileptic seizure. This is showing you the eyes closed versus squinted. This is showing you in epilepsy is very common to have a postictal yawning, and postictal means after the seizure. So a lot of yawning happening here. We have ictal grasping during a seizure event. So even during that clonic stage, very common for someone to grab onto something and they're grasping it while clonic. So for our Tasha here, the working diagnosis, of course, is functional neurological symptom disorder, but you already suspected that long ago. The family, unfortunately, was not accepting of this diagnosis. They were convinced that we missed something. They, said that Tasha has always had presented differently for everything. And that's proof that we're missing something. She's had illnesses with no physical findings in the past. On hospital day 3, she did develop seizures, non-epileptic seizures that were EEG monitored. She had 5 captured on the video because we put them on EEG monitoring with the little sticky probes all over their head or contacts all over their head. And then we also have them on video. And so we can watch what's happening at the same time we see what's happening with the brain activity. She was transferred to inpatient rehab for PT and OT, which is the treatment, by the way, and speech. And then referrals were made for cognitive behavioral therapy for functional disorders or for non-epileptic seizures. And that was the last time I saw Tasha. But this brings us to how in the heck do you talk to patients and their families? So again, and I said this throughout, this diagnosis causes mixed emotions and disbelief. Folks are kind of relieved that there's nothing life-threatening, but at the same time, they're in disbelief that this couldn't have a neurological, like overt neurological cause. So we don't use this word pseudo. We don't say it's all in your head, and we don't say these aren't real seizures. We say this is a diagnosis that's only made after a thorough medical and psychiatric evaluation are done. It's serious. It is impairing and disabling as any other condition and should be treated that way. Stress needs to be expressed by the body, either by words or symptoms. And conversion disorder or functional disorder is the body's way of blowing off steam or even sending false alarms. And so you get the idea there. We really want to validate that this is a disabling experience for the patient. The other thing to know is about half the patients, once they get a diagnosis, their symptoms resolve. The other half, they need more. So we need speech language pathology to help kind of, for lack of better words, get the mind and body working together. So occupational therapy, speech therapy, cognitive behavioral therapy, and psychodynamic therapy to really take a look at some of the root causes of these physical manifestations. And by the way, not everyone who has functional disorders, although the great majority have a trauma history, we aren't always able to identify a root cause, but the majority of patients, there is a root cause of trauma and then an activation with acute stressors. And then if there is PTSD or anxiety disorder or a co-occurring psychiatric condition, we treat that with SSRIs or neuroleptics if we need to. These are a couple of resources for you. I'm so sorry I went so long. Neurosymptoms.org, rarediseases.org. The epilepsy.com actually has really good resources. And then this is View from the Floor. It's a patient's experience. And I'll be straightforward. They're not very favorable about healthcare providers in this book, but it's a really good book. She really gets to the heart of her experience and what it's like to suffer in this way. And then Taking Control of Your Seizures is a kind of an expensive book available on Amazon. There is a patient and a therapy version. So even if a therapist has never worked with a functional patient, but they are very comfortable in CBT, they can get this workbook, the CBT model, and work through it with their patients. That's what I got.
Dr. Fox, that was fascinating. You can go ahead and stop your share.
Okay. Yes. Did I stop it or no?
Yep, you're all good. That was really, really quite fascinating. I know that we are just about at time here today. Is there anybody who has a quick question that they want to ask before we run out of time today?
Me. No.
Yeah, and I can stick around.
Hi, Nicole.
Hello. I can stick around for a couple of minutes too. I'm here in resident clinic filling in for someone, and I think I'd have till 1:15 before the residents need me to join a visit.
Oh, thank you. Yeah, I've got to get back to clinic too, but I had a quick question because we had a really hard case, and I don't know, I doubt you saw the patient. I bet Corey did. A lot of um, they were in the psychiatric hospital for quite a while, and the problem we were having is that the psychiatric hospital doesn't have OTPT, the things that I think they really needed. So they were, and part of their like sort of depression, anxiety had to do with how dysfunctional they had become with their neurological symptoms, which were pretty severe postpartum. It was a mess. And so I think what I was trying to figure out, just even logistically, is when you have someone, because they were almost at an acuity stage where going to like an inpatient rehab might have been a good idea, but no inpatient rehab will take someone who's not psychiatrically stable. And so it was more of a logistical issue, but I didn't know if you'd ever had cases like that, even in the hospital, where the dispo was complicated. I know we
We
do in so
have
many
it
ways.
almost, most of the cases are this
Yeah,
way. So what we do, at least for St. Luke's Boise, we are across the street from Elks.
yeah,
And so what will usually happen is if we can get them into Elks, my team will see them in the main hospital.
awesome.
And then we walk across the street once they've
Yeah,
gone to Elks and take care of
got
them
it.
there using the consult liaison model of psychiatry
Yeah.
as much as we can. And I don't know if there's any psychiatric hospital that has access to PTOT, but typically we try to get people to rehab first.
Yeah, I know Cottonwood. Yeah, Cottonwood didn't. I guess we could check Intermountain, but anyway, it was. Yeah, I think that's what I find. And again, it's also getting
Hard.
people every through, because if you're hitting the system in that many locations, you have to make sure that even your outpatient team that you're trying to put together actually knows what's happening, I've had that with so many people with even the psychogenic
Mhm.
attacks where people
Mhm.
will, like, their counselor will be like, I can't see them anymore because they're having these attacks, and neuro will be like, they need to see psych. And then, it just becomes a
It
bit of
can
a
be a
like, and
mess.
it's a challenging situation. So it feels like people are constantly like, and even as a primary care doctor, I get nervous that I'm missing
Mhm.
something or other.
Yeah, I
So,
kind of think this is one of those conditions that would really benefit from like a center,
mhm, for sure.
but
Yeah.
I don't know that Boise's ever going to be big enough to have that kind of
Right.
center.
Right.
Even when
Right.
we refer to our own therapy team, like, of course, people are like, what do I
Right.
do
Right.
with
Yeah.
this? I'm not
Totally.
really sure. Sure, I know how to do all the therapy models. Like I was
Yeah.
trained in all those things, but
Yeah.
but like I were trying to do something and they are like on the floor,
Right. Right.
you know.
Absolutely.
And
Oh,
and
thank you.
sometimes
Yeah.
I guess I would say if someone has an episode in your office and it's functional, because people with epilepsy can have functional attacks
Yeah.
also.
Yeah.
And so if it is telltale signs functional, it's okay to actually say, you know, you're having one of your episodes. I'll be right back.
Yeah, yeah. No,
And
we got
back out.
Dr. Yu, who works upstairs, remembers it because she came upstairs once, and I had a patient who seized every time they came in, and they were actually lying on the floor kind of halfway in the exam room, and my nurse and I were just chatting, like, because she was very comfortable, and we would sit with her. She was supported, she was fine, she was safe, and like we were there, just not, we didn't have the pulse ox on and doing all the things.
Yep.
And so I think it can be, as long as we're being kind and knowing they can hear. I know, I'm
Mhm,
sure that comes up
mhm,
in the book where
mhm.
people are
Yep.
saying things when they are fully aware of what's going on. So, yeah.
Exactly. Yeah, this is definitely one of those situations where less is more. And
Hmm.
so, when we have panicked family members or it's happening at work, and everyone is like flocking around them and really freaking out because it's very upsetting, when
Yeah.
someone looks
Yeah.
like they're having a seizure on the floor. We don't want to do nothing if it's an epileptic event.
Yeah.
Um, but less is more. This is kind of like we just kind of, oh, you're having an episode. You're going to feel better soon.
Yeah. Yeah.
Dr. Crownover, I saw you just put something in the chat. I know Dr. Fox has
Hmm.
graciously said that she'll
Awesome.
stick around for a couple more minutes. So if
Thank
people
you,
have,
Dr. Fox. Good to see you.
It's nice to see you. This is interesting. This idea of the ammonia swipes. Hey, if it works and it's not like toxic for them to inhale them.
No, I mean it works every time, and
Cool. I love
they
it.
it's benign, it's cheap. I order it from the pharmacy. The caregivers at the house. He's an adult DD. Caregivers at the house just keep it on hand, and
I'm going to start
oh,
recommending this is
I wake
great.
up. Yes, it wakes up. Everything's fine.
Like smelling salts.
Yeah,
We
yeah.
actually, yeah, it's used
Wow.
frequently in our patients at Cottonwood that we do believe are seeking Ativan injections.
hmm Well, the cure for that is to offer rectal.
We do offer that as a last resort, and we do stock that.
Oh boy. Okay, maybe it's not the cure then at your facility over there. Well, yeah, other questions. I love this ammonia idea. I'm adopting that.
Well, Dr. Fox, we actually need to wrap up on our end. I'm sorry, I know we would love to stick
No,
around
that's
and ask
okay.
all the
Thank you.
questions. We'll have to dedicate 2 sessions to this next time, but
Or
thank
I
you
can
so
talk less.
Well, thank you so much. This was a great presentation. And we'll be back in 2 weeks. I know this is a little late. A lot of people logged off, but we'll be back in 2 weeks on Wednesday, April 15th with Jeremy Stockett and Chad Freeman, who are going to be talking about supporting patients and providers through death and dying. So hope to see you then. Have a great rest of your day, everybody. Thanks, Dr. Fox.